Hello, welcome to the first part of Chapter 9, covering joints. At first glance, when you see that there are 126 slides to this PowerPoint, you're probably stressed out, but don't worry too much. Most of this is actually pictures. Okay, so 126 slides, it's not all words, a lot of it's pictures, so I think you'll find it's maybe a little less than you thought. But at the same time, it's still about the same amount of information we've done with our other chapters so far. All right, so I have broken this down into 3 parts. The first part is mainly dealing with classification of joints. So we're going to go through a lot of new terminology when it comes to the naming and the classifications of joints. The second part will deal a little more with a specific kind of joint called synovial joints, where we will hone in on the structure and function of some of the specific joints, like the knee joint, for example. And then part 3 will be mainly focused on joint pathology. So let's get started with this. First of all, what is a joint? A joint is simply where 2 bones are going to meet together. This does not necessarily mean that this location is a movable location. Some joints are not movable, as we'll see. So, basic definition of a joint or articulation is simply where 2 bones are going to meet. And so, yeah, I would say that probably one of the most challenging parts of this chapter for most students is really this first part, dealing with joint classification, because joints have a sort of a complex way that they are named. So really it's the naming, I think, that is going to be challenging for you. So, you know, I recommend writing down the names of the joints and the different classifications and kind of organizing that on a list. Now, if you're familiar with bone anatomy, the joint names are going to be a little bit easier for you. Because how are the joints named? Well, they're going to be named based on a couple of different aspects. Number one, they're going to be named based on, well, what bones are joining together. Okay, so example is here, radio-ulnar joint. So this is telling you this is a joint between the radius and the ulna. All right, so obviously, you know, your understanding of the names of the joints are largely assisted by your already existing knowledge of the names of the bones. Joints will also be named based on what kind of actions that they're going to do as well in some cases. All right, so we're going to classify the joint structurally based on what bones are coming together, and then we're also going to classify joints functionally based on what kind of actions are possible by the muscles associated with that joint. And as you'll see later when we talk about different types of joint movements, these will come into play again later on when we're studying muscle and the actions that muscles do. So let's get started with this classification. Okay, so as I mentioned, you can classify joints structurally and you can classify them functionally. So first we're going to go through the 3 main structural classifications. And then so for each of these 3, we can break these down even further into like subgroups. And then we will talk about specific examples of joints within each of these groups. So the 3 main classes of structural classification are going to be fibrous, cartilaginous, and synovial. And so what does this mean? Well, when you say fibrous joint, fibrous, what we're talking about is typically a lot of collagen. Okay, so there will be a lot of connective tissue fibers existing between the bones that are joining together. And in this case, you know, if there's a lot of fibrous connective tissue between them, then functionally you can, in most cases, if it's a fibrous joint, you can say it's immovable. Okay, there's not much room for movement there between those 2 bones. So that leads us to our three types of functional classifications. Synarthrosis or synarthroses. Again, this is going to be an immovable joint. So fibrous joints are classified as synarthroses most of the time. And let's do the next structural classification here, which is cartilaginous. Cartilaginous is what it sounds like. There will be a good deal of cartilage existing between the bones that are meeting up. Specific subclasses of cartilaginous joints include synchondroses and symphyses, which we're going to go over these. And also, I forgot to mention the three types of fibrous joints that we're going to go over. These would be sutures, Gomphoses, and Syndesmosis. So yeah, you can see how the terminology may seem a little bit more complicated, a little bit more involved. And so cartilaginous joints, because there is, in most cases, a good deal of cartilage existing between the two bones, they might be movable. They can be slightly movable. Like some cartilaginous joints are slightly movable. Others are not movable. It just depends on how much cartilage is there. If it is slightly movable, we call it an amphiarthrosis. The last structural classification is the synovial joint, and this is the one we'll be spending most of the time on. Synovial joints are very different from fibrous and cartilaginous joints because they contain a cavity. So there is more space existing between the bones that are meeting up. And we're going to see that in that cavity there's a lot more structure. Okay, there are numerous types of structures that we will find existing in a synovial cavity, and we're going to go through those. And then so that relates to the third functional classification, which is a diarthrosis. Diarthrosis means that these joints are freely movable. The only diarthroses in the body are going to be synovial joints. Okay, so synovial joints are always considered diarthroses, freely movable joints. And a lot of this, again, it relates to all the structures that we're going to find in our synovial joints, and we'll spend some time on that. All right, so let's get started with examples of each of these. We're going to start with the fibrous joints. Fibrous joints. Okay, so remember, fibrous joints can be classified functionally as synarthroses. Remember the prefix SYN means together. Okay, so this literally means bones together or bones close together. All right, so fibrous joint, these bones are going to be close together, and so therefore these are going to be considered either totally not movable, as in synarthrosis, or maybe they're slightly movable. All right, so three kinds of fibrous joints that we will talk about: sutures, Gomphoses, and Syndesmosis. The first one is sutures. And we have already seen this when we looked at the anatomy of the skull in lab, or if we haven't done that yet, we'll be doing it soon. But we already know a little bit about these, right? Sutures are representing where bones of the skull and the face have joined together. Okay, this is going to be occurring throughout youth, throughout development, throughout adolescence. We will see a continual growth of the bones of the skull and the facial bones until they meet together. All right, because when you're born, the bones of the skull are not completely fused together. You've heard of people saying soft spots, right? Like the baby has a soft spot. Well, yes, the baby does have a couple of soft spots on the head. And those are actually, that's basically just connective tissue cartilage, okay, cartilage. And over time, those bones will start to what you call ossify. And you should recognize that term. In Chapter 7, we talked about that when we talked about bone development and how bones start out as cartilage and then they will mature and ossify, right, or harden. And that's what we're going to see happen with these skull bones. Okay, so these are classified as a fibrous synarthrosis, immovable joints. Now, understand that in the beginning, right, so when we're developing, these are movable, okay, because the bones aren't totally ossified yet. So there is some movability possible there. But once you have fully matured, and it says here by middle age, sutures will ossify and fuse. So, you know, the older you get, the less movable these joints are. And again, here is a suture. We've seen these before. Remember, sagittal suture, coronal suture, we've got a lambdoid suture, and then on the lateral side we have a squamous suture. And some of them are shown again here. And then of course the face, we have many sutures located all around the facial bones. You did not have to know any of the names of those sutures, just the ones on the skull. All right, second kind of fibrous joint we're going to call a Gomphoses. And this is a specific joint where we're talking about the tooth articulating with either the mandible on the lower row of teeth, or the articulation of the teeth with the maxilla on the upper row of teeth. These are called Gomphoses. All right, and again, we're just going to have fibrous tissue, lots of collagen connecting the bones together. So, by the way, you know, with all this, when we're talking about joint classification and functional classification, you know, your questions about these are going to be pretty basic. They're going to be pretty like definition based, unless we're talking about synovial joints. Once we talk about synovial, there will be some more detail that you're required to know about. Okay, but so far for all this, most of these joints, you just want to, you know, it's just going to be memorization. You know, knowing the names of the different classes of joints. All right, so the third kind of fibrous joint is known as a syndesmosis. All right, and you know, these are similar to the other two we talked about in the sense that, yeah, it's a fibrous joint, meaning there's going to be a lot of collagen fibers there joining the bones together, but here the collagen fibers are going to be a little bit longer, so there might be some movability possible in a syndesmosis. What are examples of a syndesmosis? Well, we have this interesting relation between the radius and the ulna, and we have a similar unique relation existing between the tibia and the fibula. And so I say it's unique because between the radius and the ulna, and between the tibia and the fibula, you have this special structure called an interosseous membrane. And this interosseous membrane is just a sort of a wider sheet, basically, of fibrous tissue. And so it's pretty unique, all right? So these interosseous membranes will be what is joining the radius to the ulna, and what will join the tibia to the fibula. Now, the interosseous membrane, when we're talking about the radius in the ulna, allows us to do a special kind of movement. And I'm going to go over these later in part 2 of this chapter. But just to throw it out there now, the types of movements possible here at the radio-ulnar joint are called supination and pronation. And again, I'll just get to that later on. For now, just take note that this radio-ulnar joint has an interosseous membrane, and it is classified as a syndesmosis, where you may have some mobility possible there. And then we have a similar situation, an interosseous membrane between the tibia and fibula. Now, in this case, we are not going to have very much mobility at all. We can do very little movement between those two bones compared to the radio-ulnar joint. So here's a picture of this interosseous membrane. This is showing you the tibia and the fibula. So you can see here, there's going to be like this sheet, okay, of fibrous tissue that will connect these two bones. In the case of the tibia and fibula, very little movement is possible at this location. However, in the radio-ulnar joint, there will be movement possible. All right, so that was fibrous joints. Now let's move on to the second structural class of joints, and these are referred to as cartilaginous joints. Cartilaginous, just what it sounds like. These bones will be linked by cartilage. And our cartilaginous joints are typically classified functionally as amphiarthrosis. All right, this means that we are able to get some movement out of this area. Well, we're going to break the cartilaginous joint down into two types. We have a synchondroses and a symphyses. So let's take the first one, synchondrosis. Notice, right, we have our prefix syn, meaning close together, and we have chon or chond. That base word, whenever you see that base word, it always means cartilage. Okay, so you know if you're talking about a synchondroses, this is a joint where the bones are linked together by cartilage. All right, not collagen, cartilage, specifically hyaline cartilage. Hyaline cartilage, which you've already learned a little bit about, is the cartilage that is associated with bone. All right, where do we see these synchondroses? Well, believe it or not, the epiphyseal plates, which you learned about in chapter 7, all right, the epiphyseal plates where we find our growth zone, where we see growth and length of a bone, believe it or not, these epiphyseal plates can be classified as joints during development only. All right, so this is what it says, temporary joints. So when you're still growing in length, when you're still growing tall, the epiphyseal plates are considered slightly movable joints. All right, so these are only in children, remember. Okay, so remember where that epiphyseal plate is located, between the epiphysis and the diaphysis of your long bones. All right, and then once we're done growing in length, then of course this epiphyseal plate will ossify, as you recall, and it will no longer be considered a joint at that point. Second example of a synchondrosis is just between the first rib and the attachment to the sternum. Your other ribs are going to connect, as you remember, to the sternum by way of costal cartilage, but these joints are considered synovial joints. That means there's actually a small cavity there. All right, so the synchondrosis is only in regards to the first rib and how it attaches to the sternum. And here's a picture of that, if you can see now. Up top, we have our clavicle, and remember our clavicle is going to articulate on top of the manubrium there at the clavicular notches. And then if you look at that first rib, well, the first rib has a much tighter connection to the sternum, and this is going to be referred to as a synchondrosis. The rest, Alexa is talking right now. Oops. Sorry, hopefully that was not too much.
Here's your reminder from my daily
Okay,
mindset
Alexa's
today.
talking. Hold on. She's done. All right. So the rest of these ribs are actually connecting to the sternum by way of synovial joints. All right. And that is hyaline cartilage. Remember, that's still hyaline cartilage. All right. The second type of cartilaginous joint is called a symphysis. This is where we're going to have the two bones specifically formed by, or I'm sorry, specifically connecting by way of fibrocartilage. And so you might remember fibrocartilage is the strongest kind of cartilage that we have. So this means that the bones being joined by this is a really, really strong connection. And so a couple of examples of where you find this. The pubic symphysis. This is where you see a thick piece of fibrocartilage connecting the right and left pubic bones of the pelvis. All right, this is referred to as the pubic symphysis. Another location would be between your vertebrae. And we actually have a specific name for the fibrocartilage that connects vertebrae. We call these intervertebral discs, which you've all heard of. All right, so again, this is going to be a really strong connection between vertebrae because it's fibrocartilage. And we will have some slight movement possible, right? We do, even though this is a really strong cartilage here, we do have some flexibility there. All right, there's a picture of your intervertebral discs. Moving on to the joint classification we will spend the most amount of time on, and that will be synovial joints. So why do we spend a lot of time on synovial joints? Mainly because they are the most clinically relevant. It is in synovial joints that you will see the most when it comes to injury, when it comes to pathologies, painful conditions, things like that, wear and tear. All right, we get a lot of wear and tear in these, and later on in life you do end up seeing issues going on in synovial joints. So we will spend a little bit of time on these, again, just because they're a little more clinically relevant compared to the ones we've already talked about. So all synovial joints are classified as diarthroses, okay? They are all, in other words, diarthrotic, meaning they are freely movable. And so these synovial joints are pretty much going to be located amongst all of your limb joints. Okay, this is where we're going to find synovial joints. Some structures and characteristics of synovial joints. Synovial joints have these special structures called bursae. That is plural for bursa. And we will go through a couple of specific bursae. And I'll explain what that is when we get there. And we have tendon sheaths. What are these? These are going to be protective coverings around your tendons. Remember that tendons are connecting muscle to bone. And so, yeah, tendons can be considered part of the structure of a synovial joint. And again, we'll see these. We'll see pictures of this. And then you're going to have a number of other structures located in the synovial joints. Because we have this cavity there, we're going to find some more structure there. All right, and so this allows for stability. It also allows for an increase in the number of types of movements that you can do at these joints. Of course, like we've done with the other joint classifications, we're going to break synovial joints down into subclass, or into specific joints. The knee joint, that's really the big one. We're going to spend some time on that. The shoulder joint, elbow joint, hip joint, and right around the jaw, we're going to talk about just a couple points on the temporomandibular joint. But anyway, we're going to go through each of these, probably spending a little more time on the knee compared to any other, because the knee is a really big deal. Now, the synovial joints, because they are classified as diarthrotic, meaning freely movable, this means they have the greatest what you call range of motion, or abbreviated as ROM. If you're looking at paperwork dealing with that, if any of you go into like physical therapy or something like that, you'll probably use that abbreviation, ROM. It stands for range of motion. And so it's just meaning that there are a greater number of movements that are possible at each of these joints. Okay, so each of these joints, each of the synovial joints, will have a range of motion. All right, and so, like I said, with physical therapy or, say someone comes in and they're having shoulder pain or something, then the clinician is going to probably do a range of motion test on that person to see, are certain movements limited? Do certain movements seem to not be normal? What kind of movements can they do less? And so yeah, they're going to look at the range of motion to help try and figure out what might be going on in that joint if there's a problem. So again, so just some more characteristics about synovial joints. They are diarthrotic. There is a joint cavity there. Freely movable. These are the most structurally complex. Like I mentioned, we're going to have a lot more structure in our synovial joints. These are the most likely to develop painful dysfunction at some point in life because we do use these a great deal. Sports, okay, for athletes, their synovial joints, of course, are going to get a lot of wear and tear over time. And again, like I said, these synovial joints really are the most important for things like physical and occupational therapists, for athletic coaches, all right, that kind of stuff. So we're going to mention what kind of structures exist in a standard synovial joint. All right. Now, this one is actually showing here a joint between the metacarpals and the phalanges. This joint is specifically called the Metacarpophalangeal Joints. And yeah, these are actually synovial cavities. And we're going to go through these different parts. And actually, why don't I just go ahead and mention them now since we're on it. I know I have at least one other picture of this. All right, so you're going to have your bone here and your bone there. And actually, no, you know what? I think I have a better picture of this ahead. Yeah, let's do it this way. All right, so in words first, I will explain to you the main structures that you find in a synovial joint. First, you're going to find articular cartilage. Articular cartilage is synonymous with the term hyaline cartilage. Okay, this is just saying this is the cartilage that is found in joints, in articulations. And we know that specifically, okay, in most cases, the type of cartilage we find is hyaline, unless we're talking about the cartilagenous joints of the symphyses where we find fibrocartilage. All right, but in synovial joints, we find specifically hyaline cartilage. And so this articular cartilage is covering the ends of the bones. And this is an important location because this helps keep the ends of the bones smooth. All right, so that movement between the two bones that are joining together is smooth. Okay, this prevents crushing of the ends of the bones when we're moving. All right, it provides a smooth surface. And, over time with age, this articular cartilage does sort of wear away. It wears away over time. And this is one reason that people in later ages will or can experience some pain in their synovial joints. Okay, and it's simply just due to wear and tear, a wearing away of this articular cartilage. Also in the synovial joint, you will find a cavity. Okay, you will find a small fluid-filled space, okay, an actual cavity. And this will be existing between the two bones that are connecting. Inside of that joint cavity, you will find synovial fluid. Synovial fluid is a very important part of the synovial cavity. Another structure that you're going to find is called the articular capsule. The articular capsule is actually made of two connective tissue layers. You have an external layer and an internal layer making up this articular capsule. The external layer is a fibrous layer, and it is going to be continuous with the periosteum. You remember the periosteum. Periosteum is the membrane that lines bones. All right, and we're going to see how that is, all right, here in a minute. The second layer of the articular capsule is called the internal layer. It is the synovial membrane. Now this layer is actually what makes the synovial fluid, and it will secrete the synovial fluid into the joint cavity. All right, fourth item that we're going to find, I already mentioned, it's called the synovial fluid. Synovial fluid is pretty thick or viscous. It is slippery. You should know some of the things, some of the constituents of synovial fluid. We have hyaluronic acid and we have albumin. Albumin is a very important transport protein. Albumin transports fat-soluble proteins all throughout the body. Okay, it's a major transport protein. So synovial fluid is going to lubricate and nourish the articular cartilage. Okay, so you want to keep your synovial fluid in good shape throughout your life because this is what helps to keep your articular cartilage in good shape. All right, this fluid, the presence of it is also going to prevent friction between structures inside the synovial cavity. We also have some phagocytic cells present in the synovial fluid that have an antimicrobial effect. There will be, depending on the joint, a number of different types of ligaments that you'll find, of course, okay? Because what ligaments do is they connect bones together. So, of course, we will find ligaments, and we will talk about some of those specific ligaments. You're going to find nerves and blood vessels, all right? We have to be able to sense and we have to be able to transport items to and from this synovial cavity. We also are going to have, so specifically relating to the nerves, we are going to have receptors located in our synovial joints that are sensitive to certain sensory modalities, such as pain. Yeah, we have to know if we're feeling pain in our joints. Definitely want to know this type of receptor. This may be the first time we've talked about it. These are called proprioceptors. Proprioceptors we'll probably bring up again at some point. So proprioceptors, these are specific types of receptors, part of the nervous system, that are going to pick up information about where you are in space. These receptors detect your position in space, like are you standing up straight? Are you lying down? Are you elevated? Are you on a roller coaster? Are you it basically just detects and gives information to the brain about how you are situated in space. All right, so keep that in mind. All right, so here is your standard structure of a synovial joint. Let's just look at each one. Ligaments, yeah, definitely going to have ligaments. Remember, ligaments connect bone to bone, so we're going to have ligaments outside of this, okay, outside of the whole situation. The joint cavity, okay, the joint cavity is here. That's the space here. You can see that that is an open space. Inside of that joint cavity, we will have synovial fluid floating around. Articular cartilage, remember articular is hyaline cartilage, and that's seen in blue here. The articular cartilage will be located at the ends of your bones, at the ends. You then have your articular capsule. Remember that the articular capsule is composed of two layers. You have a fibrous layer and you have a synovial or an internal layer. The fibrous layer, actually this little line should be pointing to this purple layer. I don't know if you can see that little light purple layer. That is actually the fibrous layer. And that light purple area will be continuous with the periosteum. The periosteum, remember, is going to be a membrane lining the bone. All right, so the fibrous layer will be continuous with the periosteum. And then we have our internal layer of the articular capsule, which is shown in green here. These, I apologize, these lines are not quite pointing to the exact thing I want it to. But the green, sort of light green layer there, that is your inner articular capsule or the synovial membrane. So yeah, that has to be facing the innermost side of the synovial cavity, because it's the synovial membrane that is making and secreting synovial fluid. So obviously that layer has to be close to the inside of that joint, because we need all that synovial fluid to be secreted from that layer. All right, some more anatomy here of the synovial joint. We have menisci, okay, or meniscus is singular. And you've seen these before. In lab, we talked about, related to the knee joint, we talked about a lateral and a medial meniscus. What are these? So menisci are made of fibrocartilage. These are going to be thick pads of fibrocartilage existing between the bones that are joining up together. And these are important for absorbing shock and pressure. They help to stabilize the joint. They improve the fit between the bones that are joining up. Okay, and again, they're going to stabilize the joints, helping to reduce possibility of dislocation. All right, and then again, because of their location, the menisci are between the bones. Because of that location, it does help reduce wear and tear of the ends of the bones to some extent. Other structures, we call them accessory structures. Tons of other structures we can find in synovial joints. Tendons, as I already mentioned. Tendons, which are made of dense, regular connective tissue, as you remember. All right, these are going to be attaching muscle to bone. Ligaments, all right, also dense, regular connective tissue. We know those are going to be there. What about bursa? What are bursa? So bursa are really important little structures, and they're actually little sacs that are consisting of synovial fluid. Okay, so little sacs of synovial fluid. These are going to be situated between structures like tendon and bone, between bone and skin, and we're going to see a picture, okay, an example of where exactly you would find these bursa. And again, they are important little structures because they're going to help provide a cushion between these structures. Okay, so where tendons pass over bone, for example, you know, we don't want, every time we move, we don't want our tendons to get torn up or damaged. So we need like a little cushion there existing between the tendon and the bone. All right, and so those are going to be bursae. All right, as it says here, it helps tendons slide more easily over joints. It also helps lubricate because we do have synovial fluid in it. All right, also we're going to reduce friction just between any of the structures existing in that joint. What is a tendon sheath? I already mentioned that a little bit. A tendon sheath basically is a bursa. It is an elongated bursa, okay, that's going to wrap around a tendon because tendons are longer. So we're going to have a specialized bursa that is going to wrap around this longer tendon. All right, we call that a tendon sheath. Here is a picture of some of these bursae. And in some cases, I would like you to know the names. You should know the name of this one. It's called the Subacromial Bursa. Okay, the bursa is seen here like with this green outline, and in the middle it's yellow. That's all synovial fluid. So you can see how these bursa are important in helping to prevent friction between all the structures here. All right, up here is this structure of the scapula called the acromion. You all remember that? This acromion. Well, we don't want that acromion to be rubbing against any other structures here. So we have this perfectly situated bursa called the subacromial bursa. It's under the acromion. And this is really important for joint function. All right, if this gets damaged or if it gets inflamed, it can be very painful. Here is a tendon sheath. All right, remember a tendon sheath is going to be a long bursa. And so you can see how it is wrapping around this tendon. All right, when we talk about this is the shoulder joint. When we talk about the shoulder joint, this is a structure that I definitely want you all to know. I'll just go ahead and bring it up now. It's called the tendon of the long head of biceps brachii. So this is the tendon that is associated with the biceps brachii muscle, which you'll learn about later. The biceps brachii is a very prominent muscle on the anterior aspect of the humerus. And so the biceps brachii has a long head and a short head. The long head is here, and it is going to be wrapped by this tendon sheath to help prevent friction of that tendon, between that tendon and the humerus. Look at that, all right? So see how these bursae are very important, all right? And reason I wanted you to know about this tendon of the long head of biceps brachii is because this is really one of the main stabilizers of the entire shoulder joint, all right? This long tendon helps in a really big way to stabilize this joint. Here's just another picture of a bursa. All right, this is the same one we already looked at, subacromial bursa. Okay, and you can see that. So when you're moving, let's say you're moving your shoulder, you're moving at your shoulder, right? There will be some movement there of this humerus, right, against this ligament. But to prevent that, we have this very beautifully, perfectly placed bursa, which helps prevent friction. Not going to ask you anything specific on this slide. Just another image here of some more of your bursae. All right, we're going to have these situated all around synovial joints to help prevent friction. You can see here in the hand that we have a good number of like smaller bones. We have these small bones in the wrist called carpals. We have our phalanges, right? We have all these little bones here. And so it is going to be important to have plenty of bursae dispersed all throughout these synovial joints to prevent friction. We certainly do use the hand a lot, so we need that. This slide, I'm not asking you anything about this. I really just included it for your own interest if you're interested in learning how exercise affects articular cartilage. Range of motion. Now, you probably will have a question about this slide. Remember that range of motion is referring to the degree of movement that is possible at a synovial joint. This, as I already mentioned too, ROMs can serve as a physical assessment, okay, of a patient's joint flexibility. It can help indicate maybe what specific structures might be injured. If they move a certain way and they feel pain in that direction, that can help us say, oh, that might be that ligament or that tendon, right? So range of motion is very important in determining joint pathology. What is range of motion determined by? All right, well, it's determined by the integrity of the structure, okay, of the joint, such as how are the articular surfaces? Are the articular surfaces worn away? If they're worn away, then that means it's going to hurt when you move, so therefore that would decrease your range of motion. If you're limited by pain, right, you're not going to move as much there at that joint. All right, the ligaments, how strong are the ligaments and how tight are the ligaments? These affect range of motion. Okay, stretching of ligaments. If your ligaments are not as tight, let's say they're kind of loosened up a little bit, this will increase range of motion. Now, this is one reason that when people are exercise or getting ready to exercise, they do stretches, all right, because this helps sort of make your ligaments a little bit more lax. Okay, it's kind of like it just sort of gets them a little bit more mobile, and this will increase your range of motion. All right, just a point down here I won't ask you about, but double joint, people say double jointed. That doesn't mean they have two joints there. All right, it's a weird word. I'm not sure why they ever coined it that. But, you know, a person who's able to, basically, it looks like they're able to move at a certain joint in an unusual way. That just means they have longer or less taut ligaments. So they have a greater deal of flexibility at that joint. So therefore, they may be able to perform movements to a greater degree than the average person. They don't have two joints there, just so you know. Range of motion is also going to be determined by the muscle, right, and the tendon. All right, nervous system, when we learn about muscle, you're going to see how the brain, the spinal cord and the brain, okay, are going to play a role in this. Remember I mentioned proprioceptors. Proprioceptors are receptors of the nervous system, and so those proprioceptors detect body position and joint position and muscle tone, as we learn later. All right, so basically actions of muscles and tendons will also obviously affect how great a range of motion may be. All right, here we go. We're going to go through the classifications of synovial joints. Remember, I mentioned this first part of joints as very much related to your joint classifications. So all the names, all right, the naming of these joints. So we do have specific types of synovial joints, and here they are. There are 6 types that we're going to mention and give examples of. 6 classes of synovial joints. We have ball and socket joints, condylar joints, saddle, plane, hinge, and pivot joints. And yes, we do need to know just definition level, all right, like an example of each of these. I'm very sure you'll have a question or two, all right, about classifications of these, just basic level, all right. First of all, we have our ball and socket joints. These are just what they sound like. We're going to have the head of a bone, for example, the head of the humerus, join up with sort of a larger cup-like sockets. Okay, so in the example of shoulder joint, head of the humerus connects with the glenoid fossa, which is a fossa. It's like a cup-like socket. Examples are shoulder and hip joint. All right, so you should know the specific examples of each class. Shoulder and hip. Now, interestingly, the shoulder and hip have the greatest range of motion compared to any other type of joint. All right, these are classified as what you call multi-axial. Multi-axial means that these joints can move in several different directions, not just one direction or not just 2 directions. All right, basically multi-axial is also kind of meaning that you can do circular movements at those joints for the most part. Okay, so anyway, ball and socket joints have the highest range of motion, all right, and they're considered multi-axial. You can do multiple types of movements around an axis at that joint. Next class is condylar joints. Some people call them ellipsoid. Condylar joints, examples are the radiocarpal joint. Okay, the radius connects to carpal bones. Metacarpophalangeal joints. This is where the metacarpals meet up with the phalanges. These are called condylar joints. What do you see here? You see a convex surface on one bone fitting together with a complementary shaped depression on the other bone. These are biaxial, bi meaning 2, so we're able to do movement in 2 planes. Here's a ball and socket joint. We have our head of humerus joining with glenoid fossa and our hip joint. All right, head of femur joining with the acetabulum. Condyloid, all right, or condylar. Metacarpophalangeal joints, all right, you can see that one bone, all right, the phalanges, are going to have like this convex sort of, or concave, I should say, sorry, shape at the end of their bones, where the metacarpals will have this complementary ending, which fits perfectly into those phalangeal ends. Metacarpophalangeal. Remember, you want to know what specific joints belong in which class. Saddle joints. Saddle joints are biaxial. These joints have one bone is going to be shaped like a saddle, and the other one will be shaped, basically one is shaped concave and the other is convex. That's the answer. Examples: trapeziometacarpal. What is this? Trapezius is actually the name of a specific carpal bone that you actually don't need to know. All right, but you should know that a saddle joint exists between the trapezius and the metacarpal. This is basically right at where your thumb is located, okay? And this is why we have what you call opposable thumbs. The sternoclavicular joint, you already know that joint. That is a saddle joint. Plane joints, also known as gliding joints. These joints have flat surfaces, all right? So the ends of the bones are both going to be flat, so they just sort of slide over each other. These are also biaxial. And actually, most of our synovial joints are biaxial. Examples of the plane joints, okay? In between the individual carpal bones making up the wrist, similarly between the tarsal bones in the foot, all right, and also between certain areas of the vertebrae that you didn't need to know the articular processes. All right, unless we're talking about the transverse processes, but I probably won't ask you that detail. Here's a picture of a saddle joint. Remember the trapezium, I think I said trapezius before, sorry. Trapezius is a muscle. Trapezium is this carpal bone. Now, so there exists this saddle joint between the trapezium, which is one of your carpal bones, and the metacarpal of the thumb. All right, so right here, that's a saddle joint. All right, sternoclavicular. You can see how the clavicle just kind of sits in the clavicular notch, kind of like a saddle. Okay, it's kind of like sternoclavicular notch is like a saddle, and this clavicle sits right in it. Okay, so these are two examples of a saddle joint. Plane or gliding joints. Remember that the ends of the bones in these joints are going to be flat. Okay, both bones joining up are flat. And so we're going to be able to do like a gliding movement with that. All right, so bones between the carpals, okay, we're going to be able to do some plane or some gliding with that. The ankle, so basically in between your tarsal bones. Between articular processes of adjacent vertebrae, again, I probably won't ask you that detail. Sacroiliac joint. So the sacrum back here does join up posteriorly with the ilium. And so back there we have this, we actually have a plane joint back there. And yeah, that's synovial. So we are able to move that area. All right, and then ribs 2 through 7. All right, all the rest of your ribs except for your false ribs. So basically all of your true ribs except for rib number 1. Have that direct connection to the sternum, and these are plane joints. These are synovial joints. Okay, a couple more. Hinge joints. Hinge joint, where one bone is convex and it fits into a concave depression of another. Kind of similar to what we've already seen. These are monoaxial. They're freely movable only in one direction. You should know your hinge joints. It's kind of like opening a door. That's like what I think of when I think of this class of joint. Like the hinges on a door, right? It's just like that. We can only move that door in one plane or one direction, right? Open or close, basically. Well, our examples of hinge joints are at the elbow joint, the knee joint, joints in the fingers and joints in the toes, so your phalanges. All right, and so I think you can see how that is. If you flex at your elbow, right, or you flex at your knee, all right, that's considered monoaxial. We can only move in one direction with that. And then lastly, as I'm so very sure you're excited to hear me say lastly, the last class of joint here that we're going to mention is the pivot joint. Like hinge joints, these are monoaxial. And basically here, a bone is going to sort of spin around an axis. And we already talked about this in lab once. Between C1 and C2, right, of your vertebrae, cervical 1 and cervical 2 vertebrae, we have our atlas and axis, right? This is called the atlantoaxial joint. Remember how easy the names of joints can be as long as you know the names of your bones, okay? That's all it takes. So atlantoaxial joint. This is a pivot joint, monoaxial. You can only move in one direction. We talked about how you can move your head from left to right at this joint. Also, the humeroulnar joint at the elbow. Now, I do want to point out here, on your PowerPoint, I think it says radioulnar. I'm pretty sure it does. It should not say radioulnar. It should say humeroulnar. Okay, the humeral, where the humerus joins up with the ulna. All right, at the elbow joint. That is considered a pivot. Here are some hinge joints. We have the elbow, phalanges, and then pivot joint, where the, now you do actually, I'm sorry, I did say there was a mistake on that one slide, but it's only a typo. Basically, the radius and the ulna meet up at a place called the radial notch. And that joint right there is classified as a pivot joint. So technically, radioulnar joint, this is one of your radioulnar joints. I just didn't want to get you confused because we talked about another radioulnar joint earlier on, right? And that was with the Syndesmosis joint where we had the interosseous membrane. I just didn't want you to get confused, okay? So basically, you know, there's two different joints we can classify here on this radioulnar connection. We have a pivot joint up at the proximal part of this, and then down at the distal part, it's going to be not a synovial joint. It will be instead a syndesmosis connected by the interosseous membrane. Okay, so there is a difference, and again, I didn't want you to get confused. Atlas C1 and C2 is a pivot joint. We are starting part 2 of joints. Two main foci of this lecture. First would be all of the different kinds of movements that are possible at joints. Secondly, we will hone in on one, maybe two of our synovial joints, specifically the knee joint we will go over in this lecture. So this first part is really important, not only for the subject of joints, but also later on when we are studying muscle, the terms used to describe the different types of movement at joints, we'll see those terms again, and we will be using those terms pretty frequently when we talk about actions of muscles. All right, so this is an important topic for both lecture and lab. So first of all, as a reminder, you remember that muscles attach to bone by way of tendons. So at each end of the muscle, there will be a tendon attaching each end of the muscle to a specific bone. Now, related to this are two terms that you definitely want to know. So each muscle, okay, each tendon of that muscle is going to be referred to as either the origin or the insertion. So you should know what these mean. origin is referring to the end of the muscle or the tendon that is attached to the bone it is not moving. Okay, so every tendon, and we can even say every muscle, has an origin, and that is going to be located on the bone it is not, that muscle is not moving. And really that origin just serves as a stabilizing point. At the other end of the muscle, you will see the other tendon, and that tendon will be referred to as the insertion. Basically, the tendon is inserting onto the bone that it is going to be moving. Okay, so the origin is located on the bone that is not being moved. The other end of the muscle, that tendon, is going to be the insertion, which is attached to the bone that is moving. So these will be very important in understanding the actions of muscles later on. Okay, so I am going to go ahead and ask you about this, probably on exam 2. So you should know what origin and insertion mean. Now, when a muscle contracts, what happens is that the muscle actually shortens. And we will learn a lot of detail about that when we study muscle physiology. But in general, for now, you can just understand that when a muscle contracts, it becomes shorter. And so in that process, what will end up happening is that the insertion will actually pull on the movable bone. This will cause the insertion to actually move toward the origin. Again, this is something very important that you'll want to recall later on when we talk about muscle actions. So there are 3 main categories of types of movements that are permitted at synovial joints: gliding, angular movements, and rotation. Our main focus is going to be on angular movements. There are many more movements to understand in this category, but of course we will mention a little bit about the gliding and rotation movements as well. All we really need to say about gliding. Here is an image of this movement. Okay, so you can see how this hand is moving. Basically, our carpal bones, okay, the synovial joints existing between the carpal bones, all right, we're going to have this gliding movement possible. And a great way to study these movements is to actually practice them. So when you're going through this lecture, maybe the second time, go back through and review each movement while you're actually practicing the movement in real life. I think that really helps students when trying to understand and remember these movements. All right, so that was all we really had to say about gliding movements. Angular movements, like I said, most of our movements at synovial joints we're going to refer to as angular movements. And so an angular movement is an increase or a decrease in the angle between 2 bones. Flexion and extension. These are really the first ones, the most popular ones. Flexion is when we have a decrease in the angle of the joint. This is common at hinge joints. So for example, at the elbow, okay, so at the elbow joint, we can perform this action known as flexion. And you can see in this image, right, this man is, when he pulls his arm, his lower arm up, what's happening? We're decreasing the angle that exists here between the upper arm and lower arm. We're decreasing that angle. and that is referred to as flexion. Extension is the opposite, and you'll notice that with these angular movements, there's typically going to be an opposing action. Okay, so for every action, there is an opposing action for most of these movements. So the opposing action to flexion is extension. Extension is the opposite of flexion. So here we have an increase in the angle of the joint. Okay, and you should know these definitions for flexion extension. That might be how your question is phrased. So extension is going to be an increase in the angle of the joint. So let's say, like this man down here, he's in a flexed position, and what if he lowers his fist? What if he lowers his lower arm bones straight out? What we're doing in that case is we are increasing the angle of the joint, or making the space between those bones larger. And so that is referred to as extension. Now, a special type of movement called hyperextension. This is a movement beyond the anatomical position, and some joints, some synovial joints, you can see this as a normal action, hyperextension. One example of that would be down here at the wrist. Okay, so at the wrist joint. Straight out is considered extended because we're increasing the angle between the lower arm bones and the carpal bones, or at the wrist. Okay, so straight out, we're increasing the angle. That's extension. If we move the hand up, let me go with flexion first. If we move the hand down, okay, this is normal flexion. This is normal flexion. We are decreasing the angle between that joint. Now, hyperextension is a little weird because it doesn't really seem to go along with the extension definition. Hyperextension, though, is going to be basically a movement in the opposite direction of flexion. All right, and we can do this normally, okay, but sometimes we can have injuries where this hyperextension can go too far. All right, too far. Flexion and extension are common, as it says here, at pretty much every diarthrotic joint. The next movements, abduction and adduction. So abduction is when we move a body part away from the midline. Abduct. I think of that like if you're being abducted by aliens, you're being taken away, right? Away. So abduction is a movement away from the midline of the body. Adduction is its opposite. Adduction is when we're moving toward the midline. Circumduction is a special type of movement that is actually a combination of all of these. Circumduction, in one single motion, you can perform flexion, abduction, extension, and adduction of a limb. Circumduction, we really commonly see that at the shoulder joint. And so here are pictures, more pictures of some of these movements we already have talked about. And again, try to practice these at home. I think the information will stick with you a little better if you're actually practicing physically the movements. So here at the neck area, right? Extension is the head straight up. And then flexion is the head forward, bended down forward. And then backward would be considered hyperextension. Here's just another example going through this at the waist area. Basically, you're at your hip joint. And then here is what this would look like at the knee. Okay, so I do recommend practicing all of these movements as you go through these and you're studying these PowerPoint slides to go ahead and perform the action. We also have flexion, extension, and hyperextension illustrated at the shoulder joint here. Again, just more examples. All right. This one on here is showing actions at the hip joint. All right, and again, I'm just giving you a lot of examples of these. All right. One extra one here is called lateral flexion. Lateral flexion is when you're tilting a body part to the right or left of the midline, as shown here. Abduction and adduction. So remember, abduction is when you're moving a body part away from the midline. So this woman here is moving her arm out and away from the midline. That is abduction. If her arm is out this way and she decides to bring her arm back in closer to the body, closer to the midline, when she brings it in, that is called adduction. Okay, and other examples are given to you here. Circumduction. Okay, so yeah, circumduction is a combination of movements, and yes, we're able to do that here again at the shoulder joint. Okay, when you're doing this movement here, you're actually rotating your shoulder, rotating at the shoulder joint. So rotation, all right, rotation is when a bone is turning around on its own axis, whether that be toward or away from the midline. You can have medial rotation and lateral rotation. Now, just so you know, medial rotation can also be referred to as internal rotation. Why can it be called either one? Well, medial / internal rotation, well, we're rotating a body part toward the midline. And so, yeah, since we're going towards the medial, the midline of the body, then we can call that medial rotation or internal rotation. Opposite of that would be lateral rotation or external rotation, where we're rotating a body part away from the midline. All right, and there are several examples of this. All right, so for example, with our atlantoaxial joint here between C1 and C2, right? If you turn your head to the left or right, that would be considered external or lateral rotation because you're moving your head or your face away from the midline. Facing directly in the middle, or if we're bringing the face to the middle, then this would be called medial or internal rotation. Here are more examples of lateral and medial rotation. Again, you can practice these. So now we get into some special movements that are allowed at certain synovial joints. Definitely want to know about the special movements. You will be asked. And these will come up again in muscle action as well. So special movements, let's start with supination and pronation. This is a very unique both of these are very unique movements that we can have at our radio-ulnar joint. Okay, so the radius and ulna. Remember the interosseous membrane that I mentioned that is existing between the radius and ulna, right? Well, this is where we're going to see this type of motion. So supination, what is supination? Supination is when you move your forearm so that it turns your palm to face anterior or upward. All right, so supination, I remember some people call this supination, and that makes you think of like a bowl of soup. So if you're standing there and you're holding a bowl of soup in your palm, you are in the supinated position. Okay, so normally, the radius and ulna are parallel. All right, now in the supinated position, that's the case. All right. What is pronation? Pronation is the opposite of supination. This is where we do a movement that turns the palm either downward, okay, facing the floor, or we turn the palm posterior. So either one of these directions, okay, this is considered pronation. And this is where we get that very unique movement where actually we're going to have the radius rotate over the ulna so that they are no longer parallel. All right, and basically what's happening is that the radial head, you remember the head of the radius is very rounded, that radial head literally spins in the radial notch located on the ulna. So again, practice these. Dorsiflexion and plantar flexion. These are special movements of the foot, okay, around the ankle joint. Dorsiflexion and plantar flexion. Dorsi. So this prefix dorsi, really you want to think of this as being the top part. Whoops. It's the top part. Sorry for that. Y'all can have a little laugh right there. Dorsi is referring to the top parts of the foot. So what this means is that we're actually moving the foot upward. Okay, so dorsiflexion at the ankle, we're moving the foot upward so that your toes are pointed up or they're pointed towards the tibia. That is dorsiflexion. Plantar flexion is the opposite. This is like ballerina, right? This is when you are pointing your toes downward. The bottom of the foot is often referred to as the plantar region or the plantar surface. Okay, so we're pointing our toes downward. Here is the illustration of this special movement of the radius over the ulna when we do pronation. Okay, supination is when we have our radius and ulna parallel. You can see that the palm is facing anterior there for supination. And then in pronation, where that radius, remember, is going to rotate around the ulna, all right, so that the bones, these two bones are no longer parallel. Here's another view of this. Dorsiflexion and plantar flexion. So dorsiflexion, we're bringing the toes upward closer to the tibia. All right, dorsiflexion. Plantar flexion, we're pointing the toes downward, away from the tibia. Or at least away from the anterior part of the tibia. More special movements, inversion and eversion. You will see these again. Inversion and eversion. Inversion is when the sole of the foot is facing medially towards the midline of the body. You turn your foot medially. Eversion is the opposite of inversion, so that the lateral aspect of the foot is facing out laterally. Protraction and retraction. So really, we mainly use these terms in relation to movement of the temporomandibular joint, so the mandible. Protraction is when basically the mandible is the bottom. Let me just say it's kind of like taking your bottom teeth and jutting them out forward beyond your top row of teeth, something like that. You're basically having an anterior movement, okay, of this at this joint. Retraction is the opposite. Here we're going to, in the example of the mandible, we're going to be pulling the mandible backward towards the neck. Here is your illustration of eversion and inversion of the foot at the ankle joint. All right, so eversion is when the lateral aspect of your foot is pointing more laterally. Eversion, just like as shown in this picture on the right. The lateral aspect of the foot as being pointed upwards or outwards. Inversion then is the opposite. This is when we take the medial side of the foot and turn it medially towards the midline of the body, like shown on this picture in the left here. Protraction and retraction. Now, you can do this at a few different places, but probably the more popular area to use these terms would be in relation to the mandible. All right, so protraction, we're moving our mandible anterior. Retraction, we're moving our mandible posterior. Other special movements, elevation and depression. These are just what they sound like. So elevation, this is when we're going to lift a body part upwards. This would be like shrugging your shoulders. Depression is when we're going to lower a body part. An example of that would be like when we're opening the mouth. Opposition. Really our great example of this is on the thumb. Okay, so with the thumb, we're able to touch every single tip of every other finger. All right, you can't do that with your other fingers. You can only do that with the thumb. Okay, so the thumb has this unique way of moving, and we call that opposition. Pictures again, elevation of mandible is when the mouth is closed. Depression of the mandible, the mouth is open. Shoulders are shrugged up here, that's elevation. Dropping them back down is depression. Opposition is with the thumb, right? We're able to take our thumb and touch the tip of every single digit. Opposition. Some other special movements, particularly with the mandible, we have something called lateral excursion and medial excursion. This is kind of like grinding your teeth. So these aren't really movements that you want to be doing, okay? But of course we have a name for them. Lateral excursion and medial excursion, basically just grinding your teeth. Okay, so those were your movements at joints. Please be sure that you know all of your movements very well. Please do practice them. You will be questioned about those on exam 2, and later on when we do muscle, both for lecture and lab, we will revisit all of those movements as we talk about muscle actions. So definitely want to know your actions. Now let's switch gears and go into the specifics of really one of the most popular synovial joints, the knee joint. Okay, so we're going to go into some specifics with this one. We really don't have the time to go into the specifics of every synovial joint, so we're really going to just focus on a couple here. And then, of course, the knee joint is, along with the shoulder joint, are really the most clinically relevant joints. This is where you're going to see the most problems in patients, would be like knee and shoulder for the most part. Yeah, so the knee joint is the largest and most complex joint of the body. There's a lot of structure in there. Now, as far as what types of movements that it does, well, it depends, all right? So the knee joint is capable of slight rotation and lateral gliding when the knee is flexed, and so you can practice this. If you're sitting down on something and make it so your feet are not touching the floor, you can do some rotation there with your knee flexed. A little bit of lateral gliding when the knee is flexed, okay? And this is really going to be associated with the patellofemoral joints too, okay? So the patella, or the kneecap, does connect with the femur, and this makes up a joint, and we can do some gliding there. What other types of movements can we do? Well, this would be at another aspect of the knee joint, where you have what's called the tibiofemoral joint. Yeah, so look, you have a lateral joint and a medial joint as part of the knee. You also have a femoral patellar joint. Okay, so there are actually 3 joints that make up the knee joint. This is why it's considered a more complex joint. All right, number 1, I already mentioned, we have a femoropatellar joint. This is where we see gliding. This is the connection between the patella and the femur. We can do gliding and a little bit of rotation there when the knee is flexed. We then have a lateral joint and a medial joint. Okay, so basically the lateral joint is just the lateral aspect of the knee joint. The medial joint is containing the medial part of the knee joint. Now the lateral and medial joints together are called the tibiofemoral joint. Okay, your tibia connects to the femur, but the fibula does not directly attach to the femur. Okay, it's just the tibia and the femur. All right, and so the lateral joint and medial joint together can be referred to as the tibiofemoral joint. And then remember, you're going to have menisci. You're going to have menisci in these 2 areas. You will have a lateral meniscus, right? And you will have a medial meniscus. Now, it's really at this joint that we are able to do our hinge-related joint actions, flexion and extension. Okay, it's that specific joint that makes flexion and extension possible. You should know the difference. You should know, that basically the knee joint can be divided into 3 main parts. All right, you should know what type of movement is allowed at which specific part of the knee joint. Here's a picture of this. Now in lab, you probably have already looked at some of these structures. Okay, this is a view where you can see some of your ligaments. The posterior cruciate ligament, the anterior cruciate ligament, we have your patella, we have your, this is a bursa that you should know. This is called the subcutaneous pre-patellar bursa. This is, like it says, subcutaneous, so it's somewhat superficial. And this is going to be in front or anterior to the patella. Okay, so we do have this special bursa here, okay, right over the anterior aspect of the knee joint, over that patella. You should know the name of that. It's called the subcutaneous pre-patellar bursa. I probably won't ask you about this other bursa. Let's look at this one up here, the Supra Patellar bursa. This one I might ask you about. All right, Supra Patellar. Supra means above. So this bursa is above the patella. Okay, Supra Patellar, so that's another. And again, remember how these bursae are situated. They're going to be existing between tendons and bones so that there is no friction between the tendon and the bone. All right, and these are areas, bursae do represent areas where you can get some pathology or some sort of inflammation. All right, if we get inflammation of any of these, whether that be due to overuse of the joint, or maybe a virus or something or a bacterium got in there and is causing an infection. But yeah, you can have inflammation of these bursae, you know, which would cause redness around the area, pain. We're going to have some fluid accumulation there. All right, so really, don't forget about your menisci, lateral meniscus, lateral meniscus. Those are really the main parts here. All right, so the patellar ligament we've mentioned before, I believe. The patellar ligament is going to attach to the distal part of the femur, cross over the patella, and then attach at the tibial tuberosity on your tibia. This is an important little location. This is where we elicit something known as the knee-jerk reflex. This is when you take a reflex hammer. We've all had this done to us, and maybe you have done it before on others. But we take a little reflex hammer and we tap on the patellar ligament, and you should see a response. What response are we going to see? We're actually going to see extension, just slight extension at the knee. I won't ask you about that yet. I mean, just be aware that for now, just be aware that the patellar ligament is the site at which we perform this knee-jerk reflex. All right, you already know these parts. We have a fibular collateral ligament and a tibial collateral ligament. Don't forget about those. Now, we're always going to have some structures that are designed to help give stability to a joint. And so for the knee joint, that would be the tendon of the quadriceps, which is located anterior. All right, and remember your menisci and the function of these. These are going to absorb shock. And they're also going to help stabilize the joint. A little bit more here about the ligaments ACL and PCL. I do predict you will have a question about this slide. Your knowledge of this slide will matter. ACL attaches to the anterior tibia. This is why it's called the anterior cruciate ligament. And you should know what's so important about this ligament. The ACL helps to prevent forward sliding of the tibia. All right, so this ligament is very important in helping to prevent injury or dislocation. All right, as all ligaments do. So the ACL prevents forward, think forward, anterior, right? The ACL prevents forward sliding of the tibia. Okay, very important ligament. And it is a common site of knee injury, especially in sports. What about the PCL, posterior cruciate ligament? Well, it's called posterior because it attaches to the posterior part of the tibia. And what does it really function to do? It helps prevent backward sliding of the tibia. Think backward, posterior. Prevents backward sliding of the tibia. And you know what would come with that would be a simultaneous forward sliding of the femur. Okay, so definitely want to know these definitions here, right, for what the functions of the ACL and PCL are. The knee joint. Yeah, we're going to have plenty of bursae there located in that knee joint. I'm not going to ask that you know all of the bursae, but I have underlined a few here that you should know. We have 4 in the anterior aspect of the knee joint. We have a superficial infrapatellar, a suprapatellar, a pre-patellar, and a deep infrapatellar. And I should have a picture here of all those. And we have a popliteal bursa. And there are more that you don't need to know about. All right, here's what we're doing is we're looking at the top of the tibia here. Here's the anterior, here's the posterior, and we're looking down at the top and just seeing a little bit more about how the structure is. So the ACL, all right, anterior cruciate ligament, there it is, and it's going to attach to the anterior part of the tibia and prevent forward dislocation of the tibia. PCL is going to attach to the posterior aspect of the tibia, and it will serve to help prevent backward sliding of the tibia away from the femur. Medial meniscus, all right, and then we have our lateral meniscus. Underneath that, we're going to find our articular cartilage covering each bone, covering the tibia and the femur. Here's another look, all right, of the knee joint here. Mainly all I'm was trying to point out are a couple of these ligaments that you've already seen. Tibial collateral ligament. You've got your fibular collateral ligament, your patella. Here is your tendon of the quadriceps muscle. All right, this is one of the main stabilizers, this tendon. You can see how that would help to really help stabilize this knee joint. Okay, that's all though. I will not ask you about the retinaculums. Another real detailed close-up look of that knee joint. Okay, here's the knee joint again. Just showing you multiple pictures of it. Here's a actual human dissection of a knee. And again, pointing all the parts out if you want to see what that looks like on the human. All right, so knee injuries. Let's talk a little bit about that. So yeah, knee injuries. The knee is highly vulnerable, okay, because you know, we do tend to get a lot of use out of this joint. We end up putting rotational stress on this joint. Okay, look here how this football player is landing. That's not very fun. Okay, so basically the knee is sort of rotating laterally in this example, and it may go a little too far and cause an injury. Most common injuries are going to be to the menisci and to the anterior cruciate ligament. Here's your anterior cruciate ligament. Okay, so you should definitely know that. Most common injuries are to the ACL or the menisci. Now, knee injuries are going to heal very slowly, and there are a couple of reasons for that. Think about what these ligaments are made of. Think about what your menisci are made of. All right. Now, menisci in particular are going to be made of fibrocartilage. Fibrocartilage is very, very dense collagen. And we actually don't have a really large blood supply there in those menisci. We also do not have a very large blood supply surrounding our ligaments. Okay, so this is one reason why we're going to have slow healing take place here, because the blood supply is pretty low here in the knee joint. Okay, so it'll take a while to get all those healing nutrients to the area to help heal it. Arthroscopy or arthroscopic surgery is just a procedure in which we're going to be able to visualize the interior of this joint, all right? And so this is very commonly done when we have a knee issue. We're going to get in there and look and see what's going on, okay? Common knee injuries, you should definitely know this. Common knee injuries involve what are called the 3 C's. We're talking about collateral ligaments are more commonly damaged. Okay, so tibial collateral or fibular collateral ligaments. The cruciate ligaments, all right, so ACL or PCL, but remember ACL is more common to damage. And then of course your menisci, okay, so cartilage. So the 3 C's, collateral ligaments, cruciate ligaments, cartilage. And I want to talk about a specific kind of injury which results from a lateral blow to an extended knee. This sounds so specific, doesn't it? It is specific, but you actually may see this more commonly than you might expect. And really the main reason for that is that the lateral aspect of the knee is the most exposed, right? It's facing out. So, compared to the medial aspect of the knee, well, the lateral aspect of the knee would much more likely get injured due to something outside hitting it compared to the other side of the knee, okay? So lateral blows to an extended knee result in something called the unhappy triad. So you definitely want to know what this unhappy triad is and how this could happen and what it's going to look like. So unhappy triad, obviously we're talking about 3 parts. So yes, with a lateral blow to an extended knee, you can damage 3 parts. The tibial collateral ligament. Now that might not initially make sense because you know the tibial collateral ligament is on the medial side. But we're going to see how we end up getting damage to the medial side from a lateral injury. All right, so tibial collateral ligament will be damaged. The medial meniscus will be damaged. Again, you're like, why is this the case if we're getting a damage to the the lateral part of the knee? Why is the medial damaged? But yeah, okay, we're going to have the medial meniscus. And then the third structure that to make up this unhappy triad is the ACL. Okay, so these 3 specific structures will be damaged if there is a strong enough blow to the lateral part of an extended knee. And let's see why. Let's look at a picture of why a blow to the lateral side of the knee is actually going to damage the medial side. Very interesting. This relates to physics as well. If anyone has ever taken physics, this kind of relates to that a little bit, some of your concepts in physics. All right, so what happens here? Let's say it's a hockey puck, all right, and this person gets hit on the lateral side of the knee here. Well, what that does is it places pressure. It obviously puts enormous pressure on the lateral side, okay, but your fibular collateral ligament is going to be okay, all right, in most cases. And then what that causes to happen is this momentum, okay, from this object. It's like a force, a momentum that is going to transfer over to the medial side. You can imagine that in this action, you will end up seeing the femur and the tibia come apart from each other on the medial side. All right, so yes, we're going to have all these parts on the medial side get damaged. The tibial collateral ligament will tear. when that happens, okay, that's really the first thing that's going to happen. First, your tibial collateral ligament is torn. Now, the tibial collateral ligament is attached to the medial meniscus. All right, it actually is kind of continuous with the medial meniscus. So naturally, if you are tearing the tibial collateral ligament, that will pull part of the tibial collateral ligament away from its attachment to the medial meniscus. So then, therefore, you end up getting a torn medial meniscus. All right, and then also as a part of this, you know, again, we're having our femur at the medial side disconnect basically with the tibia. And so this is going to cause a tearing of the ACL as well. All right, so you should definitely know this, the unhappy triad, right? This is kind of a nightmare if it happens in a person because, yeah, you've got to fix all these. All right, got to fix all those. Healing will take a very long time. It can be done, yeah, but it'll take a long time to heal from that. Let's see. I actually think that might be a good place to stop. So let's go ahead and stop there. And I'll pick up with part 3, the last parts, starting at this slide where we will talk about the temporomandibular joint. All right, everybody, practice your actions. Know that knee joint pretty well. And I'll talk to you later.